right, let's take a couple of minutes to talk about syncope, super common presentation in the emergency department, and it's defined as a transient loss of consciousness with spontaneous return to baseline. There are lots of tests that are commonly ordered in patients with syncope, but the vast majority of these are unnecessary in most circumstances. You don't need to get a head CT unless they had symptoms concerning for a subarachnoid hemorrhage before the syncope or they had a significant head trauma after the syncope. Troponins are unnecessary in the vast majority of patients unless they had symptoms concerning for ACS before or after the syncopal event. A finger stick is easy enough to get, but it seems unlikely that the patient had significant hypoglycemia causing syncope, had a return to consciousness without any treatment, and still has hypoglycemia. The two tests that you should get is an ECG and a beta HCG in anybody that could be pregnant. There are a host of abnormalities we're looking for. Clearly, we're looking for frank signs of ischemia. We're looking for those high-degree AV blocks. And then there are 5 changes that we are looking for that are subtle that can hint at the patient having had a lethal dysrhythmia that led to that syncope. That's arrhythmogenic right ventricular cardiomyopathy, Brugada, WPW, prolonged QTc, and hypertrophic cardiomyopathy. We have to be scouring the ECG looking for those findings, and that's why the ECG is the only mandatory piece in the workup of every patient with syncope.